Hello, ladies and gentlemen, and thank you for joining us. My name is Aaron Cohen. Our guest today is Dr. Amir Dehdashti from Cushing Neuroscience Institute. He's the Director of Cerebrovascular Research there. He'll be talking to us about some of the more technically challenging procedures, which include a bypass and revascularization techniques for complex aneurysms. Amir, thanks for being with us.
Aaron, thank you very much. It's a pleasure to be here. Thanks for your invitation, and very happy to share my experience with you.
You're welcome. Regarding our disclosures, Dr. Dehdashti has no disclosures, and my disclosure is consulting for Zeiss Meditech. So with that in mind, Amir, please take it away.
Thank you, Aaron. So we decided to talk about cerebral revascularization for complex aneurysms. When I look at my experience over the last 5 years of about 50 intracranial bypass surgery, about 22 were done for aneurysms. So it's not really half, but close to that number. And I try to pick few of those cases that are in terms of the technical and decision making or more challenging, and obviously the achievement of this bypass per se and the postoperative outcomes are also a formidable challenge for us. So I'm going to start here with the first case. This is a 45-year-old gentleman who was actually recently moved to the US from London and had some headache and obviously get a CAT scan. And that will identify, unfortunately, a large, rather giant, partially thrombosed NC aneurysm. We can see the imaging here. So this patient is completely neurologically intact, young, completely active. He's a lawyer, and he has this large, giant, it's exactly 2.5 centimeter aneurysm that you can see on this imaging. I'll take the pointer here. So on the CTA, you will see this aneurysm has some enhancement at the MCA bifurcation. The rest is all thrombosis around the aneurysm, and there's some enhancement at the periphery. You can see the extension of the aneurysm to the temporal base here, and you can see here exactly the part of the aneurysm which is filled by contrast, and the rest is all calcified and thrombosed. And this is the 3D imaging of the angiogram showing the patent part of the aneurysm. And obviously, we cannot see the rest of the aneurysm, which is a huge mass here that I'm delineating here with the red dot. This is the whole aneurysm here. So in a young patient, we would like to treat this aneurysm. The natural history of this giant aneurysm, even if they are thrombosed, is not very good, unfortunately. And this will pose a different and difficult challenge because of the possibility of non-clippability of this aneurysm. So maybe I can just have your opinion, Aaron, on this particular case. Do you think, or what would be the percentage that you quote the patient in this particular aneurysm based on this imaging that you or the neurosurgeon would be able to clip this aneurysm as opposed to other surgical alternatives?
Yeah, I mean, that's an excellent question. I would say the chance is extremely high. This is a very calcified aneurysm in a young patient. I completely agree with you that treatment of the aneurysm is indicated. I would say the chance of clipping this aneurysm primarily is almost close to zero. The surgeon has to be completely ready for a revascularization procedure. It's on the dominant side. I would say this is a very tough case.
And for this reason, as you can see, I evaluated also the external circulation. You can see there is a very good tortuous, but good parietal branch of the SCA. The frontal branch, unfortunately, is very bad. It's there, but it's very tiny. And it's obvious that if we want to revascularize this, we have to revascularize both MCA distal to the bifurcation, something which basically needs 2 bypass. And by looking at this imaging, we have one good candidate for bypass, but the second one is really tiny. So this evaluation was done prior to surgery. And when I talked to the patient, the same way as you described, we try to clip the aneurysm, but be really ready to perform a trapping of the aneurysm and bypass if deemed necessary. We also had the arm and the leg evaluated and prepped in case we need some extra graft for the bypass. So if you can kind